Good morning. I'm Liz Goldstein, Executive Director of the Anticoagulation Forum. Thank you so much for taking the time out of your day to join us. We had over 1,200 people register, so I'm just going to give a minute for everyone to log in. See how the logins are coming. Okay, we're up almost to 500 already. I am so excited to introduce an all-star AC Forum panel for this webinar discussing perioperative management of anticoagulation. Can you clear my patient for a procedure, which was published in Hematology in December 2021. We are very lucky to be joined by all three authors, Drs. Allison, Burnett, Bishoy, Ragheb, and Scott Kaatz. Next slide, please. Once we get there, Dr. Allison, thank you. Dr. Allison Burnett is the Antithrombosis Stewardship Specialist at the University of New Mexico Hospital. She's an incredible advocate for safe and high quality care through the Antithrombosis Stewardship model, and we are thrilled to have her lead us by serving as president of the AC Forum. Allison is following in the footsteps of a giant, Dr. Scott Kaatz, who is the immediate past president of the AC Forum. Scott is Senior Staff Hospitalist and Medical Director for Professional Development and Research at Henry Ford Hospital. Dr. Bishoy Ragheb is the Anticoagulation Program Manager at the Tennessee Valley Health Systems VA and serves as board member and chair of the AC Forum's flagship Centers of Excellence program. We are fortunate to also be joined by Dr. Andrea van Beek, a relatively new AC Forum board member and co-chair of this webinar program. Andrea is the Anticoagulation Clinic nurse practitioner at Visalia Medical Clinic. And last, but of course not least, Dr. Arthur Allen is the Anticoagulation Program Manager at the VA Salt Lake City Healthcare System, also an AC Forum board member and co-chair of our webinar program. Thank you so much for being here today. Next slide, please. Here are faculty disclosures. Next slide. This webinar is accredited for physician, nurses, and pharmacists. Please visit AC Forum's website or the link on the slide to claim your credit. Ashley is also putting the link into the chat box. Next slide. As always, please feel free to ask questions during the presentation using the Q&A box. The chat has been disabled. Thank you again to our speakers and to everyone joining us today for what I expect will be a very fun and lively discussion. I'd like to now introduce Dr. Andrea van Beek to present an overview of the paper and some interesting cases. Thank you very much.
Welcome, everyone. We're glad to have you here for this talk on perioperative management and interruption of anticoagulant agents. Before we get started today, I'd like to thank the authors, Allison Burnett, Bishoy Ragheb, and Dr. Scott Kaatz for their work on this very important paper. I'd also like to make a special mention and give thanks to lead author Allison Burnett. Allison recently did a presentation for ASH on this paper, and when I discussed with her our plan to present the paper in this setting, she graciously sent me her slides and presentation. If you've heard her ASH talk, you'll find the slides in this talk to be very similar. So thanks, Allison. You're making me look way smarter than I actually am. The objective of this presentation is to discuss perioperative anticoagulation management. With an estimated 6 to 8 million people in the United States on an oral anticoagulant and approximately 10% of those requiring temporary interruption for an invasive procedure each year, this is a common situation we are seeing in everyday clinical practice. And it's an area that has evolved quite significantly in recent years due to both transition to the DOACs, as well as a shift away from bridging for most of our warfarin patients. The objectives of today's presentation are that after the next hour or so, you should be able to describe the pharmacokinetic differences between the DOACs and warfarin and how their management around invasive procedures dramatically differs. Also, you should be able to discuss approaches for assessing both thromboembolic and bleeding risk to aid you in developing a perioperative plan that is individualized to your patient. And finally, you'll be able to employ a simple stepwise approach that will help you standardize perioperative anticoagulation management that is based on the existing evidence as well as expert consensus. Step 1 involves asking if the anticoagulant even needs to be interrupted. And if so, you move on to step 2, which is consideration for which anticoagulation agent the patient is on, because management is going to be dramatically different between the DOACs and warfarin. Step 3 is ensuring safe and appropriately timed resumption of the anticoagulant to avoid adverse outcomes. We'll walk you through these 3 steps with a few clinical situations to help you understand how to employ this approach in your own clinical setting. Even though we started with steps 1, 2, and 3, there is one other step which should be considered, and I'm calling it step 0. And in all reality, it probably should come before you move through the actions of considering if an anticoagulant needs to be interrupted. In the anticoagulation clinic, we are often the ones asked to stop these agents, but we should consider if it is even safe for the patient to stop their anticoagulant agent temporarily. We should think about whether they have had a recent TIA or CVA, or if their bioprosthetic valve occurred less than 3 months ago, or if they've had a recent venous thromboembolism. If any of these are the case, we should consider if the patient can delay the procedure safely. Another consideration could be if it would be safe to proceed with the procedure with the patient on the anticoagulant agent. This does require using a shared decision-making approach and is an important element of anticoagulation stewardship. This shared decision-making should occur between the patient, the anticoagulation clinic, the cardiologist or neurologist, or even primary care, depending on the type of event which has occurred. It is essential to also include the proceduralist in this decision-making. I'd like to briefly review the comparative pharmacology of the available oral anticoagulants. As you know, warfarin has a very long half-life of about 40 hours or so, so it has a very slow offset and slow onset, which makes its management very complex. Conversely, all of the DOACs have a much shorter half-life of about 12 hours on average. We should also consider the peak effect of the various anticoagulants when planning post-procedure resumption, as we know the DOAC's onset is just hours, whereas warfarin takes several days to fully kick in. Renal function should be considered around invasive procedures, particularly in patients who have renal insufficiency. The DOACs have made our lives significantly easier surrounding procedural management, eliminating prolonged hold times or overlapping with a parenteral agent, as we have to do sometimes with warfarin. Unfortunately, in practice, we often see providers trying to manage DOACs similarly to what they know from warfarin, which is inappropriate and can lead to severe patient harm. So let's take a look at this clinical case to get a better understanding of this. This is a 65-year-old female patient who is planned to undergo an elective right hip replacement. Her past medical history includes a bioprosthetic aortic valve, non-valvular atrial fibrillation, hypertension, and diabetes. She has a CHADS-2 VAS score of 4. Her labs including her liver and renal function are normal, and she is referred to you in the anticoagulation clinic for periprocedural anticoagulation management and recommendations. Let's take a closer look at step 1. Interruption of the anticoagulant is primarily based on the bleeding risk of the procedure, but the patient's individual bleeding risk should also be considered. Unfortunately, we don't have any validated bleeding risk tools that are specific to the perioperative period. In practice, clinicians often use commonly known bleeding risk factors, such as the ones listed here. This list is not exhaustive, but it is a good starting point. Many of these factors are not modifiable, but it is good to be aware of their presence so you can anticipate and manage any potential complications. One risk factor that does deserve a special mention is antiplatelet agents, and these may or may not need to be interrupted for the procedure. I really think it's best practice whenever possible to discuss this with the prescriber of the antiplatelet, such as the cardiologist or neurologist, to determine the best plan for the patient. When meeting with the patient for this periprocedural visit, it also offers us the opportunity to evaluate if a patient really needs to be on an antiplatelet agent, or if these patients could even, or if these medications could even be permanently discontinued. Again, a conversation that needs a multidisciplinary approach. Next, we need to consider procedural bleeding risks. There are several tools to help us with this, and they are all essentially derived from surgical society opinions and estimates from the literature. So just be aware that the categorization and recommendations can vary. This particular tool is derived from ISTH, and you can see it includes a wide array of procedures. It is important for clinicians to be aware that when subspecialties like GI, orthopedics, or interventional radiology are involved, they may be relying on guidance from their own individual societies, and so their recommendations may differ. Again, we see the importance of why a multidisciplinary discussion is so critical. Very importantly, there are a number of minimal bleeding risk procedures which do not require interruption or where continuation of anticoagulation is actually shown to be safer. These are procedures that include implantable cardiac devices and minor dental procedures. So remember, whenever you can, try to keep things simple. For our patient undergoing the hip replacement surgery, this would be considered a high bleed risk procedure, and so it would warrant interruption of the anticoagulant. Step 2 is based on which anticoagulant the patient is taking, because management is going to differ dramatically between the DOACs and Warfarin, particularly in regards to bridging. Bridging is defined as the use of a shorter acting agent like low molecular weight heparin in place of a longer acting anticoagulant around the procedure to minimize the time with subtherapeutic anticoagulation levels. The DOACs are themselves short acting with a half-life of about 12 hours. Due to this quick off and on, we do not need to hold them for extended periods. Also, bridging is not indicated as you would be replacing one shorter acting medication for another. Warfarin, on the other hand, is more complex, and as I mentioned previously, it requires longer hold times and occasionally consideration for bridging. Again, this is a big advantage of the DOACs over Warfarin. You can simply stop and restart the DOAC at the appropriate times around the procedure. And this was confirmed in the PAUSE study, which was a non-comparative multi-center cohort of about 3,000 atrial fibrillation patients who required temporary interruption of the DOAC for an elective procedure. The investigators used a simple perioperative protocol that was based on the half-life of the drug, the patient's renal function, and the bleeding risk of the procedure. They did not do any bridging or any preoperative lab measurements. You can see from the diagram that this is a very straightforward approach of holding 1 day before and 1 day after for low bleed risk procedures, and 2 days before and 2 to 3 days after for high risk bleeding procedures. The timed resumption of anticoagulation, which is step 3 of our stepwise approach, is very important to mitigate bleeding risk because of the rapid onset of the DOACs. Some patients are also at high risk of post-op DVT, so we can use what we call a step-up approach of prophylaxis in the interim, shown in the light green, until we can safely get our patient back up to a therapeutic strength of their anticoagulant. Overall, in the PAUSE study, there were very low rates of major bleeding and thromboembolism, and over 90% of patients had minimal or no residual anticoagulant activity. So with these positive results, this is becoming a standard approach in many healthcare settings. While this study was conducted in atrial fibrillation patients, and we do readily extrapolate this to other indications such as venous thromboembolism. So getting back to our patient undergoing the hip replacement, if she is on a DOAC, we can have her hold for 2 days prior and then resume therapeutic anticoagulation 2 to 3 days after, once hemostasis is achieved, and we can use VTE prophylaxis doses of anticoagulation in the interim. If our patient is on warfarin, the management will differ. We need to consider the patient's thromboembolic risk as well as the need for bridging. So many of us know how bridging works, but I think it is worth our time to take a look at this schema developed by Arthur Allen. He's one of our board members and really a true anticoagulation guru and one of the moderators on this call. As we all know, we typically stop warfarin about 5 days before procedures. And once the INR starts to drift down, once it drops below 2, we note that the patient is not fully anticoagulated. The patient then has their procedure and hopefully restarts their warfarin the night of the procedure. So gradually, their INR will start to rise with time, hopefully getting back into a therapeutic level around day 4 or 5 post-op, if we're lucky. So without bridging, that patient is typically left unprotected or without anticoagulation from anywhere from 8 to 10 days or even longer in some cases. So insert low molecular weight heparin. Now the patient is anticoagulated other than the small window of time when they're having their procedure. In theory, low molecular weight heparin makes sense as we all want to ensure our patient does not clot. However, in practice and from the literature, we know that patients do have bleeding with low molecular weight heparin, so we do reserve bridging for just the highest risk clot patients. The first standardized bridging guideline came from the ACCP back in 2008, and then there was an update in 2012. As many of you know, this resource has really been the go-to source for perioperative anticoagulation management. The authors use estimates from the literature as well as their own experience to categorize underlying thromboembolic risk for mechanical valves, AFib, and VTE. There is an important background to be aware of with these guidelines. First, the concept of bridging is largely based on biologic plausibility and expert consensus. Also, these annualized thromboembolic rates you see on the left are derived from outside of the perioperative period. In the most recent guideline update, the authors did acknowledge that the optimal intensity of bridging is not known, but they allude to preference for therapeutic intensity because we don't have any data to show that prophylactic anticoagulation prevents arterial thrombotic events in AFib or valves. For VTE, they do acknowledge that there is data showing post-op prophylaxis does prevent VTE, but they do not go so far as to recommend this approach. In 2015, the BRIDGE trial was published, and this was the first prospective randomized controlled trial on this subject. The trial included more than 1,800 atrial fibrillation patients who were randomized to standard perioperative low molecular weight heparin or placebo. It is important to know that the majority of patients in this trial did have a CHADS-2 score of 4 or less, so the highest risk AFib patients may not have been adequately represented. Ultimately, the results showed that foregoing bridging did not lead to more arterial thromboembolism, but were more significantly safer with regard to major bleeding. Shortly after the BRIDGE trial was published, the American College of Cardiology issued a consensus pathway of perioperative management of oral anticoagulants in atrial fibrillation. In 2017, they updated their recommendations by using the CHADS-2 VASC score for thromboembolic risk stratification. The recommendations in regards to use of bridging therapy did not really differ from the older CHEST recommendations, which surprised many of us. We see here that bridging should be reserved for only the very highest risk patients, which are those who were not studied in the BRIDGE trial. Even though very few warfarin patients still require bridging, it is helpful to discuss a few practical management pearls. I'd like to draw your attention to just a few things. First, to that last bullet point, the bridge with low molecular weight heparin only needs to continue until the INR is greater than or equal to 2, even if the patient has a higher target INR range, like someone with a 2.5 to 3.5, because we do not have any data that we need to bridge all the way up to that higher INR. Also, a full 5 days of overlap with warfarin and low molecular weight heparin is not needed because the patient does not have an acute thrombotic event, and this is not induction. So again, the bridge should be stopped as soon as the INR is greater than or equal to 2. Getting back to our hip replacement patient, we would not bridge due to the CHADS-VASC score of 4, but hip replacement surgery does have a high incidence of post-op VTE, so the use of post-op VTE prophylaxis is imperative. Let's look at another case of a 57-year-old male with a history of an unprovoked proximal DVT 4 months ago who is on therapeutic anticoagulation. His past medical history is significant for a polypectomy for a precancerous polyp about a year ago, and he is planning to undergo a surveillance colonoscopy in 2 weeks. His gastroenterologist has referred him to you for perioperative anticoagulation recommendations. So first, we need to assess if it is safe to stop his anticoagulant. He did have that DVT 4 months ago. We know that the first 3 months following a VTE event are a no-stop zone, if at all possible, and we're through that, so we can proceed with determining if the anticoagulant needs to be interrupted. Now, a routine colonoscopy without biopsy or polypectomy where they're just going to go in and look, is generally considered a low bleed risk procedure. But if intervention is needed, like a polypectomy, and then the procedure may become high risk. So in cases where there is a high probability for this type of situation, the proceduralist will most likely want to interrupt anticoagulation. And for DOAC patients, this is easily managed with the pause protocol by holding for 1 day prior, since this is a low bleed risk procedure. And then you can adjust your post-procedure resumption based on whether or not interventions such as the polypectomy were done. For warfarin, again, things are more complex and can require holding for a few days, and in some cases, consideration for bridging based on the patient's thromboembolic risk. It should be noted as well that our GI colleagues, their societies also do recommend staying on anticoagulation for these type of procedures. Really, they become high bleed risk once there's multiple polyps removed or a large single polyp. So it does become a little bit sticky, and it is important to collaborate with your GI colleagues. In this case, we were dealing with a DVT that occurred 4 months ago. Unfortunately, we do not have any randomized prospective data for VTE like we do with the bridge trial for atrial fibrillation. But what we do have is a recent systematic review from 2019 of 28 observational studies conducted on patients who were taking chronic warfarin for secondary prevention of VTE. This pooled data included nearly 7,000 patients and looked at the incidence of thromboembolism and bleeding. And you can see there was an increased risk of major and any bleeding with bridging therapy, and that the bridging did not change the rates of recurrent VTE. Based on concern for lack of benefit and potential increased patient harm, the most recent VTE guidelines from ASH strongly recommend against bridging in both low and moderate risk patients. The ASH authors did not specifically address the highest risk VTE patients, so that makes it a bit challenging to know what to do with these patients and does lead to some variations in practice. For our patient, his DVT was 4 months ago, so we would not bridge, but we might give him a slightly boosted warfarin dose for a couple nights after the procedure, which is a strategy that was shown by Sam Schulman and colleagues to safely and effectively expedite return to a therapeutic INR. Next, we have a 72-year-old male who is scheduled for an elective total knee replacement in 4 weeks. He is on warfarin for a bileaflet mechanical mitral valve with a target INR of 2.5 to 3.5. His labs and vitals are within normal limits, and his orthopedic surgeon is asking you in the anticoagulation clinic for perioperative anticoagulation recommendations. Recent guidelines we have on valvular heart disease were published by ACC and AHA in 2020, and they, like others, have evolved in regards to bridging. The authors cited growing concerns seen in other indications like AFib and VTE as a major stimulus for the revised recommendations. In these latest guidelines, a low-risk patient is given strong recommendation against bridging. And for both moderate and high-risk mechanical valve patients, they state that bridging specifically in the preoperative period is reasonable, but with no mention of what to do in the postoperative period, which puts some of us in the trenches in an interesting spot. Periop 2, which is the only prospective randomized data we have on mechanical valves, including nearly 1,500 patients at risk for thromboembolism from either AFib or mechanical valve who required warfarin for interruption for an elective procedure. The valve subgroup consisted of 305 patients, and anyone with multiple mechanical valves, older type valves, history of stroke or TIA, they were excluded. So these essentially were non-high risk patients. Everyone received preoperative bridging with therapeutic dalteparin, and then were randomized postoperatively to receive either prophylactic or therapeutic dose dalteparin based on their bleeding risk of the procedure, or they were randomized to placebo. At 90 days, there was no significant difference in thromboembolic events between those who were bridged and those who were not. And there were more major bleeding issues in the bridge group. So the investigators did conclude that there is likely no benefit from the post-procedure bridging in patients with non-high-risk valves. And this is what we see reflected in the ACC and AHA guidelines on the previous slide. Getting back to our patient who is planning to undergo a total knee replacement, we would first confirm with the surgeon that interruption of the anticoagulation agent is needed. And then, based on the evidence we just reviewed, preoperative bridging seems reasonable as long as the bleeding risk is not excessive. In the post-op period, though, it is less clear what we should do, but at minimum, the patient does need to have VTE prophylaxis after this total knee replacement. It is likely, however, that full bridging is not indicated. So how do I do perioperative management in my anticoagulation clinic? I have an anticoagulation clinic that I started about 4 years ago. And so I like to give you kind of just a boots on the ground, practical description of what I do. So all of my patients know that they need to call me if they are scheduled for a surgery or procedure. And at every touch point with my patients, we always ask them if they are scheduled for any surgeries or procedures. Typically, they know something is coming, so they will give me a heads up. And we do ask them for at least a 2-week notification prior to the surgery or procedure, which will allow them time to be seen in the office. Once they have their procedure date scheduled, we set up a visit in the anticoagulation clinic, which is typically 30 minutes in duration. Ahead of that visit, I create their perioperative schedule. This usually involves a discussion with the surgeon to determine their preferences and understand if they are okay with our protocol. I assess the patient's lab values, assess their CHA2DS2-VASc score if applicable, along with the bleed risk of the surgery and their individual bleed risk. During the patient's visit, I present the perioperative schedule to the patient in writing, and we discuss that. We discuss risks associated with being off their anticoagulant. I am careful to document this thoroughly in the medical record, which is important to me from a liability standpoint. I do give each patient 2 copies of their schedule, one to keep at home or keep on their person the day of the procedure, and the other one is given to the staff at the hospital or the surgery center for their record. Additionally, I do fax or hand deliver a copy to their proceduralist's office. If bridging is indicated for the patient, I will place an order for the enoxaparin or the other bridging agent during the patient's visit with me. And I do ask patients to call me if the cost is too high when they go to pick it up at their pharmacy. I tend to use GoodRx if that is the case, and it does help bring down the price significantly. Here's an example of the bridging instruction sheet, which I give to my patients. I fill in the dates appropriately, as well as the dose of the Lovenox and Warfarin. I use a similar instruction sheet for DOAC interruption, and I find that this process works really well as long as the patient reads their instructions carefully. For patients who require bridging, I go over the administration technique with them during their visit. I do have some Lovenox syringes in my office so they can see what the syringes will look like. It is important to tailor your education to how your patient learns. It's helpful to ask them if they learn best by reading, demonstration, or by watching a video. For some, I show them a YouTube video of the administration technique, whereas for others, they need to see and touch the actual syringe to understand the technique. I also give all of my bridging patients the handout that you see here on the screen so they have something to walk them through the steps at home. The take-home points from this session are that evidence and guidelines on perioperative anticoagulation management have evolved significantly over the last decade, and hopefully all of you now have an increased appreciation that DOACs and warfarin have dramatically different pharmacokinetics and require different management strategies around procedures. Finally, management can be fairly straightforward by using a simple stepwise 1-2-3 approach, while also considering if it is safe for a patient to interrupt their anticoagulant agent. I would be remiss to not make a note of perioperative strategies for pediatric patients. Most pediatric practices in anticoagulation are extrapolated from adult data, and perioperative anticoagulation management follows this trend. Similar strategies are employed for pediatric patients who need to interrupt their anticoagulants as their adult counterparts. I will leave you with some resources which you may find helpful when performing perioperative anticoagulation consults and recommendations. I'd like to sincerely thank you for your time and attention, and I look forward to the Q&A session to follow. And I'm going to now hand it over to Allison Burnett, who is going to provide some comments.
Well, thank you, Andrea, for an excellent presentation, very clear and comprehensive overview of the topic. And I think you've set us up very nicely for some very good discussion on the webinar today. It was an honor for me to write this invited manuscript with my colleagues, Dr. Scott Kaatz and Bishoy Ragheb, for, as you mentioned, the American Society of Hematology meeting this last December. It was part of a session on consultative hematology, so consults that hematologists often get in the hospital. And so Arthur wanted me to be sure to clarify on the title, can you clear my patient for a procedure? Obviously, a lot of us on the call aren't going to independently be clearing patients for procedures. More so, we're going to be focused on the antithrombotic management for these patients, which is important, not just to us as clinicians, but also to our patients, because it's a period of high vulnerability for them. And obviously a very hot topic, given the number of attendees that have signed up for this webinar today, and the number of excellent questions that we got before the webinar and that continue to roll in. And so to leave time for lots of good discussion and to get us started here, I'm going to hand it over to my friend and colleague, Dr. Arthur Allen.
All right. Well, as a great Texan, Matthew McConaughey says, all right, all right, all right. This is excellent conversation, guys. This is a topic that's always bringing folks out of the woodwork to try to clarify. We see a lot of the same answers over the year, questions over the years, because sometimes there aren't great answers. And so I want to leave lots of time for question and answer, try to do this as rapid fire as we can. We got a lot of questions before and a lot of questions coming in now. One of the most common questions still is, should we be using low molecular weight heparin bridging for patients prescribed DOACs? And I know we all see this. So I'm going to kick this over. I think I'm going to kick it over to Bishoy, because I know there's a little history there.
Yeah, appreciate it, Arthur. So that is common. Again, I think you're probably famous for saying we've waited 60 years to get a drug that is different than warfarin, yet when we get it, we treat it just like warfarin. So yeah, with DOACs, there should be, I hate to use absolutes, but really no time that we would bridge with the DOACs. The pharmacokinetic parameters are very similar, if not the same as rivaroxaban, as the low molecular weight heparins. The only time that you could maybe consider, and this is actually in the ASRA guidelines, are in patients with very, very, very high risk, where we're talking about hours make a difference in terms of prophylaxis for VTEs, but it should not be 99.5% of the time. We should not be bridging the DOACs just because, again, we're almost taking an oral medication and giving it by injection, if you will.
Yeah, Scott, please. I bet you're going to follow up on this as well.
Yeah, Bishoy, I agree. But if hours is so important, that patient probably didn't go to the operating room in the first place.
Yeah.
I mean, hours would be ginormous pulmonary embolism and we're doing surgery the next day. That ain't going to happen. So yeah, it's not 99.5. 99 point a lot of nines after that for number one. Number two, though, I do think probably a reasonable is in your high, but not stupidly high risk patient that can't ingest an oral medication. So the ileus after a big abdominal surgery, where even though you have an NG tube and you can put it down the tube, it's maybe still not going to get absorbed. And I know we have to look at, because you have some DOACs that are absorbed in the stomach and some that are absorbed in the intestines. That's maybe the only time that I can think that it would make sense.
Yes, Allison, please.
Yeah, really quickly, just to piggyback on that. So this also happens, pre-operatively, right? We set somebody up with an interruption of their DOAC for whatever reason, their procedure gets bumped, delayed, et cetera. If you don't know when that procedure is going to get rescheduled, and particularly if they're, they are MPO, then that's another situation where you might use a parenteral in lieu of a direct oral anticoagulant. But I just want to point out, the math says that if you're holding a DOAC for 2 days with the half-life of 12, roughly 12 hours in normal renal function. When you go into that second day, you've already got 25, you've still got 25% of that drug on board. And if you're trying to wedge a dose of therapeutic enoxaparin in there, you're going to get your patient to super therapeutic. And I think we have, you know, good evidence that this is not a good thing to do. We have sub-analyses from Rocket and Rely. We also have the Dresden registry saying bleeding is increased when you bridge the DOACs. So don't bridge the DOACs with low molecular weight heparin.
Yeah, and I think the one last thing that I would say that hasn't been covered is it's often important to think about VTE prophylaxis that we as an outpatient service may not be thinking of. This recently came up with my service where, you know, we know a patient's going in for a hip. We say you don't need to bridge because of the patient's AFib and CHAS vascular. But don't forget about good VTE prophylaxis. And by the way, I don't think that just starting a patient on warfarin cold, which is one of the options, by the way, is a great option. And so we had a patient go in who was having big abdominal surgery for cancer. Well, there's VTE prophylaxis guidance there as well. And so I think that it's important that we do incorporate, you don't need to bridge based on what we mean by bridge, but don't forget about VTE prophylaxis post-op. So.
Yeah, Arthur, excellent point as usual. But right, you can use low molecular weight heparin on post-op day 1 and 2 while you're waiting to restart your DOAC, right, but you're not bridging. Correct. For the AFib. Right. What you're doing is you're doing good VTE prophylaxis. Correct. And then someone in a question alluded to our first case, which was a hip replacement. Remember, you can use DOACs as VTE prophylaxis. Skip all the patient has another indication for that. So sometimes that's handy, is you can drop to a prophylactic dose of rivaroxaban or apixaban, and then on post-op day 3, because this is a high bleeding risk procedure, go back on their therapeutic dose that you're doing for stroke prevention and atrial fibrillation.
Exactly.
Yeah, great points, everybody. What about the thought of using a DOAC as the bridging agent, especially if a patient, you know, would there ever be a reason to do that? Say a patient is very adverse to injectables. Anybody?
I saw a heavy head shake from Scott, but go ahead, Allison.
Well, if you can bridge with a DOAC, my first question is can this patient be on a DOAC long-term? I think that should be, you know, and I think I'll just point out, perioperative evaluations are an excellent opportunity to exercise stewardship in so many ways, right? You're taking a timeout, a deep dive into this patient's medications, their anticoagulants, their antiplatelets. So if you're looking at a warfarin patient and thinking about, do I need to bridge or not? Maybe they can be a DOAC candidate, and there's a better switch that could be facilitated. You can also think about those antiplatelet de-escalations, et cetera. I do know that sometimes we have to get creative in practice. And if we were in a situation where perhaps a warfarin patient needed to be bridged, but the enoxaparin injections were just unaffordable, they can be very expensive for patients, even if you're, you know, using, as Andrea, excellent recommendation to use GoodRx. Sometimes I've heard of clinicians using a 30-day sample card for one of the DOACs. I don't personally do that. I think it would require a lot of hands-on and making sure that the patient understands that it is for a very finite period of time. And then in the postoperative period, when are you going to draw that INR level? So the impact of the DOAC is at a nadir. And then making sure they're not taking 2 anticoagulants when they get home. So I think it's pretty tricky. So I don't typically use DOAC as a bridging agent.
Yeah, can we just remind ourselves that bridging is off-label enough? Even the bridging we've been doing for the last 20 years is off-label enough. We don't need to complicate that. Scott, you had a thought?
Yeah, well, the problem with that from a pharmacodynamic standpoint is and I'll talk about apixaban and rivaroxaban because that's what we use mostly in the US, is that they increase the INR. So when you're getting your INR above 2 with your warfarin at day 4 or 5, you don't know how much of that is warfarin and how much of that is apixaban or rivaroxaban. And then if you stop that, the next day your INRs will be low. So you don't know what your INRs mean with the combination of the two drugs. That's a real pragmatic reason why you can't do it.
A really good reason. It could also be a problem preoperatively if you're using a preoperative bridge and they go and they get coax done prior to their surgery and their INR's out because you've been using a DOAC as a bridging agent. You could see a canceled procedure because of that. So excellent point, something that I hadn't actually thought about. And to Allison's point about it's a good time to take a deep dive. Listen, I've come across patients where you evaluate for whatever reason, say periprocedural, and you go, this patient's been on warfarin for 7 years for a saphenous vein clot. What's going on here? I mean, so it could be that you're actually realizing things that you haven't realized with regard to, do they even need to be anticoagulated? Can they be in a DOAC? Do they need their concomitant antiplatelet therapy? Let's not forget to do more than just a periprocedural management in these cases. So,
Absolutely.
Andrea, you have another question queued up for us?
Sure. So one thing I've dealt with in my practice is, the surgeon sends the patient over to me, or the cardiologist wants me to take the patient off their anticoagulant for procedure. And then they want me to bridge the DOAC, or they want to hold the DOAC for 5 days. And I would love to hear some opinions regarding how to discuss that situation with the surgeon, how to come up with an evidence-based approach rather than, taking someone off their DOAC and putting them on heparin for, 5 days. That's just not we know it's not the right thing to do, but how do we have that discussion with our colleagues in a respectful manner while providing education?
Yeah, so, this comes down to shared decision-making. And I think something that we presuppose in shared decision-making is that everyone is operating with the same set of facts and the same information. So in these cases here, again, I know we've had this warfarin mindset for 60 years. And, I think coming to a provider who's doing a surgery, or any of the surgeons, coming from an angle of understanding, because we're not the ones who have the patient on the table, they do, and they have concerns, which could, may be legitimate, but sitting down with them, and we're doing this here locally as well, where we sit down with our surgery team and say, okay, here's the actual evidence. If we move beyond this, number one, we have patient harms, but number two, a liability standpoint for you as a proceduralist. If you hold for 5 days, what can you use to support that? And putting all those facets together, I think, is important, and letting. I think we have such an antagonistic environment within medicine where people don't collaborate. We think that we're at each other's throats, or we're at each other in terms of basically warring. But if we come and say, hey, we're trying to be on the same team and we're trying to help each other out, I think that would kind of ease the tensions a little bit, and we'll be able to work more collaboratively.
Go ahead, Scott.
Yes,
I
sir.
usually get on the phone with the surgeon and say, are you nuts? What are you thinking about? Oh, come on.
That just
now, I
undid
don't do
everything
that.
Bishoy
But
just.
820 people on this call are so thinking that.
Well, Scott's my plan B. I get him on the phone and I say, can you just call my surgeon?
But yeah, you just got to explain to them, because they don't know. And that's okay. That's our job, is to be the experts and to know and to reassure them. And the beauty is we have the pause data now that really quantifies the clinical safety and the outcomes of that approach, because up until the pause study, everything was just based on kinetics. The American Society of Regional Anesthesia guidelines are based on kinetics. The American College of Cardiology's consensus pathway is based on kinetics. Remember, those were written prior to pause. We will, in another week or so, we haven't updated yet, shame on us, but we're going to re-update our internal protocols, because we have not incorporated pause yet.
Yeah, and arguably pause is based on kinetics. It's just made it, it's actually just really, really simple. And it's kind of like, it's a broad blanket approach about assumptions that can be made. Whereas the prior approach is, what are the expected kinetics in the individual patient? We can now make kind of broader assumptions, I think, so.
But Arthur, what it did is it showed that the kinetics are safe.
and simple.
Based on the kinetics. Just because it makes sense based on kinetics doesn't mean that it makes sense clinically. And pause tells us that that makes sense.
Right. Let's not create more chaos than we have to in our own lives. Right. Gotcha. So,
Allison, you had a comment?
Yeah, I just want to comment really quickly on that. So, you know, I think there's the egregious ones that we see that come in and they're like, hold your apixaban for 5 to 7 days, et cetera. Clearly inappropriate and needing an educational intervention. And, you know, then you have cases where, you know, it's more subtle, right? It's like, you want to hold for 4 days, but I'm thinking 2. And in those situations, I really want to meet that clinician where they're at to understand what's happening. You know, I prefer face-to-face when I can, a phone call, a Zoom, whatever it takes. And it's possible that when we have that conversation, they're basing their recommendations on their societal guidance, which doesn't jive with the tool that I'm using, because there's not one single universal tool, unfortunately. So I think it's good to tease that out. And then if those differences exist because it's, you know, across societies, see how we can come to consensus within our own institution and marry those things up going forward. I'll say alternatively, if I get an egregiously wrong plan from, let's say, a rural provider here in New Mexico and et cetera, and I inherit that patient, I really try to do educational outreach and find out, you know, how can I get in touch with this provider, et cetera, have a phone conversation. I love to get their email and send them resources. And I love to point them to the centers of excellence and say, hey, I'm going to empower you with all this information so you can get this right every time going forward. So capitalize on those educational interventions.
Excellent. Yeah, I think that we as thrombosis providers, we tend to focus almost too much on the thrombotic risk. There are data out there that suggests that in the peri-procedural period, when, oh, by the way, we're coming at patients with sharp objects, right? In the peri-procedural period, the risk of thrombosis, the risk of bleeding is about 10 times higher than the risk of the thrombotic event in general. And so, but what we tend to do is go, no, you can't do 3 days, you got to do 2. When in fact, we should err to the side of a wider window in the peri-procedural period, because thrombotic events are extraordinarily rare peri-procedurally.
Yeah. Also, the guidelines, the two major, a couple of the major ones, American College of Chest Physicians, American College of Cardiology, and the American Society of Regional Anesthesia. If you take the American Society of Regional Anesthesia, and I'll concentrate on rivaroxaban and apixaban again, they say hold 72 hours when they're thinking about putting needles in the back next to the spinal cord. But remember, they're pretty close, because a lot of people read pause and say high bleeding or anesthesia risk procedure, hold for 2 days. But it's made simple. You're holding for 2 calendar days. The average time of hold was 63 hours, okay? And 63 hours isn't nearly as far away from 72 hours as people tend to see 2 days, and they think that's 48 hours. And they think they're a full day apart. They're not. They're a half day apart with the guideline and the pause protocol.
Excellent point, Scott. Thanks for bringing that up. Got a question here that comes up. How much warfarin boosting is recommended when restarting post-procedurally? So you're on warfarin, you can't get away from it. You know, it was mentioned in the talk that you might expect a therapeutic INR at day 4 and 5, but you know, if you're starting a patient's prior dose back and their dose found, that could actually be a week or longer. And that's what we should kind of probably expect. So what about warfarin dose boosting?
Yeah, I think
I'll throw that to Bishoy. Go ahead.
I jumped in, I threw it to myself. I think we can maybe divide this into 3 categories. There's the one that you mentioned, Arthur, where you just kind of started off without any boosting. Number 2 was what was done in the Periop 2 trial, where they double dosed the first day post-op. And then number 3 was the one that was alluded to earlier by Andrea, the Schulman paper, which I think also included John Eichelboom and the late Clive Claron. They double dosed the first 2 days. And the reason, if you read their paper, this was from 2014, I think I was in middle school at the time, they said that they noticed in their practice, whenever they double dosed just 1 day, it still took a while for patients to get to therapeutic INR. So they decided to do 2 days. And what they found is, I think about 50% of the patients hit therapeutic INR at day 5, and at day 10, it was around 87% versus I think somewhere around maybe 5 to 12% or 67% the other run. So in our practice, we tend to do a double dose for the first 2 days. However, the one caveat here is we give general recommendations to the patient and to the surgeon and say, here's what we're recommending. I don't know what the patient's going to look like post-op. You make the final call when this is all said and done, because something could have gone wrong with the procedure or something like so. You know, they may have to change that around, but making sure that the loops of communication are closed here is going to be very important.
That's a really important point, Bishoy. And so I practice primarily in the inpatient setting, and so we do need to make sure that we're touching base with the surgical team the day of the surgery, make sure everything went according to plan. And if I recall correctly in that Schulman paper, that those were patients who were not expected to be in the hospital for more than a day. So kind of essentially like outpatient, right? When we have somebody on the inpatient side that we anticipate is going to be in the hospital for a longer period of time, maybe with, you know, altered dietary intake, some, you know, perhaps drug interactions, we back off of that. At least at my hospital, we back off of that double dose and we just do a 50% boost for a couple of days, just in case they're a little bit more warfarin sensitive.
Yeah. Yeah. And I think, you know, there's been a lot of practices over the years built around this, but to be able to quote a couple of objective data points like you did, Bishoy, is quite helpful. So thank you for doing that.
Along those lines, Allison, can you touch on a little bit of like transitions of care, any other like miscellaneous pearls you might have with, you know, coordinating care and you know, this is a really important thing with anticoagulation stewardship about making sure we close loops and communicate on a multidisciplinary, you know, sort of platform. How do you have any other, you know, advice for our folks who are just, you know, in the trenches about how to do that, or, you know, things that might be important to include?
Sure. I mean, you know, transitions of care is challenging, as we all know, but, you know, I think if you look at surgical patients, and I think Bishoy actually recommended for the manuscript, he included an excellent reference that said, you know, surgical patients in the perioperative period, you know, patients needing anticoagulation undergo something like 15 care transitions, right? So lots of dangerous junctures. And so, I mean, I think just from a high level, one, you need to have some sort of protocolized process, right? And that's not just me saying that, that's the Joint Commission saying element of performance 3, you need to have a peri-procedural protocol if you want to be accredited. Elements of that protocol need to include effective identification of these patients. So they're not showing up for their procedure on their anticoagulant and procedures are getting canceled or there's patient harm. So identification of the patients, a clear and efficient way to document and communicate the plan to all relevant parties, including the, you know, most importantly, the patient. And then, as I mentioned in my previous comments on the inpatient side, as these patients come through the OR, touching base with the surgical team that the day of the procedure to make sure everything went as they thought it was going to in the OR and there were no complications, they're not going to need to go back. To make sure that that kind of standard routine post-operative plan is still viable, and then, you know, safely transitioning on. And then as they get ready, the patient gets ready to transition out of the hospital back into the next care setting, empowering them with all the information and medications that they might need. And then it's always good for care transitions to have some sort of at least semi-warm handoff and possibly a follow-up phone call to make sure everything's going as you think it's supposed to be going.
Great points. Great points. Arthur, do you have one last question for us?
Sure. So we have a couple of questions about the use, about what do we do for dialysis patients? So patients have they're on dialysis or end-stage renal disease, and we feel like they need to be bridged for a procedure. Historically, that might mean admission for IV heparin. There are options like sub-Q outpatient heparin. The one specific question asked about low-dose Lovenox specifically, and then the option that's not presented in the question is just don't stink and bridge. Which, but can we address what do we believe and how can we simplify this? The use of low molecular weight heparin and for dialysis patients who need to bridge. I'll throw that out there. Scott.
Well, I'm not a big fan of using low molecular weight heparin in dialysis patients. If I'm pushed and I have to do it, then I will, but I don't like it very much. But I agree, sometimes when you start thinking about having somebody in for 7, 8 days, a dialysis patient, to bridge their warfarin for a fairly, a minor procedure that would only be a 2-day length of stay, it just doesn't seem practical or right, and everybody's going to question it, as they should. So sometimes I'll do it, but I don't like it.
Allison, how about you? With the patient setting?
But the other thing
Go
is
ahead.
then, here with the dialysis patient, particularly when Andrea, you showed a great slide of the ACC and ASH guidelines. If I'm in that middle category, it's a no for bridging. It's only I have this conversation in the real high risk folks.
Yeah, I think in those situations, I mean, I'm a fan of the let's really scrutinize if we have to absolutely bridge this patient. That would be my first and foremost step. And then to Scott's point, I guess if I got forced to have to use a low molecular weight heparin, I don't have it on my formulary, but if I was forced into that situation, I would figure out how to get dalteparin, which is less renally accumulated than enoxaparin, and there's more data for that in the short term. So I guess that could be an option.
Yeah, in fact, Allison, I do the exact same thing. We have a critical care study using in dialysis with dalteparin and stuff. That's exactly what I would do. And there's where, if this is a planned procedure, then you can do that. Like the patient should probably have the dalteparin before they go to the operating room, so they have it at home when they get discharged.
Yeah.
Yeah, I was hoping that would come up, dalteparin being preferred in that setting. All right, kicking it back.
Hey, well, thank you so much. That was such a fun and engaging conversation. We had over 850 attendees on today. Clearly a ton of interest and questions on the topic. Thank you to all of our speakers, Drs. Andrea Van Beek, Dr. Allison Burnett, Scott Kaatz, Bishoy, Ragheb, and Arthur Allen for your expert guidance, really practical expertise here. We're so lucky to have you all on the AC Forum team. As usual, this webinar has been recorded and will be posted on the AC Forum website in a few days. As I mentioned at the start, this program is accredited for pharmacists, nurses, and physicians, and you can find the link here or on the AC Forum website. Our next webinar is coming up on February 24th, DOAC versus DOAC, Lessons Learned from Claims-Based Observational Studies, with Dr. Jeffrey Barnes, Wayne Ray, Catherine Murray, and Arthur Allen moderating. And I'd like to thank our corporate sponsors for supporting this program. Thank you very much for joining us, and have a great day.